Welcome to the Helpful Pharmacist Podcast. My name is Kris. I am a pharmacist and a biochemist. And today we are continuing our education series and talking about health and all the things that affect it. The last couple of weeks, the focus has been diabetes, and we're going to continue on that theme. And today we're going to take a step back and break down the differences between the different types of diabetes. This is a question we get asked really commonly, whether it's from patients, family, the community, all of the above. There's a lot of confusion. And so we want to give you a nice, really simple, easy answer. So let's get into it. Again, talking about diabetes, so we're going to give some background on that. And the common theme here with all the talks we give, all the information interactions, is that knowledge is power. That's really the goal here. There's a lot of misunderstanding, misconceptions, and myths that exist with health, and diabetes is no exception. And the goal is to help people understand the facts of what's going on so they can make better decisions. And I also just want to give another quick example that a lot of things have terminology, and that terminology can be confusing. And unfortunately, diabetes is a classic example. So again, one of the key parts of today is using really simple terms to explain concepts in a simple way so that you can actually have a real takeaway and a real understanding of what we're talking about. And just to give an example, what I mean by that is that your body typically uses carbohydrates, proteins, and fats for energy. But when we talk about diabetes, a lot of those terms get kind of used interchangeably. So we have carbs versus carbohydrates, we have sugar versus blood sugar, and we have sugar versus glucose versus carbs. So effectively in that example, all those terms are either the same or very similar. So typically carbohydrates are which we eat in our food, like things like bread and pasta are high in carbs or carbohydrates. Carbohydrates are a form of sugar, and the type of sugar that our body typically wants to get out from those is glucose. So you can kind of see how carbs, carbohydrates, sugar, and glucose are all basically the same thing. And then we have what people may call blood sugar or blood glucose. And so now we can kind of see how those terms are interchanged. So I just want to set that off with that example and also provide that information because that's a really common question I get. I also just want to again mention the ideas that you're eating food, which provides the carbs, carbohydrates, or glucose, which then gets absorbed and digested through the stomach and the intestines. Eventually that sugar or glucose makes its way to the blood, and that's where diabetes really comes into play. So once the glucose is in the blood, we have to get it out of the blood to get to the site of action. So you can kind of think of, imagine you're at the gas station. Just because you're at the gas station doesn't mean that the gas is in your tank, right? You have to pump it into the tank. That's where insulin comes in. Insulin is kind of like the pump in this analogy, and it's basically what's necessary for your body to get the sugar or the glucose from the blood into the actual tissues or cells where it's going to be utilized. And what we're going to talk about today is that there's issues in that process. That's typically what diabetes is. So again, the takeaway from that part is that without insulin, enough insulin, or insulin sensitivity, we cannot get the sugar or the glucose from our blood into our cells. And again, that's what we're going to talk about today. So there's generally speaking 4 types of diabetes, or 3 types, I should say, in a 4th subclass. So we have prediabetes, type 1 diabetes, type 2 diabetes, and also gestational diabetes, which typically only affects pregnant women, just to kind of give a basic overview. Prediabetes is typically when they have early warning signs or issues with a dysfunction of how their body uses or transports the sugar or the glucose. And those typically can be due to things like diet or insulin production or some combination of that. We're going to go into that in greater detail. Type 2 is typically when the body can not actually make any more insulin, so you're no longer making any insulin. There's still not 100% consensus as the actual cause. It is known to be autoimmune, which means the body's own immune system attacks the cells. In this case, it's going to be the beta cells on the pancreas. That's where the insulin is actually made. It is generally thought to be viral in nature. So the patient either then or previously has some type of a viral infection that then causes the immune system to behave differently and become autoimmune, which then attacks the beta cells, damages or destroys them. And basically the patient can no longer make any insulin. So that's the hallmark of type 1, can't make insulin. Type 2, which is the most common form of diabetes in the United States, it's about 90% of all the cases, is more so classified as insulin resistance. So you cannot respond to the insulin you do have, or you basically can't make enough. So it's some combination of both of those. We're going to go into that detail more. But basically either overproduction of insulin, which results in not being able to make enough in the future, or resistance. And these things are often due to things like lifestyle. So it can be eating, too many processed foods, too many carbs, not exercising, not maintaining your weight, combination of things like that. And like we mentioned, we also have gestational diabetes, which is only found in pregnancy or pregnant women. And this effectively results from the hormonal changes during pregnancy. Part of it is that the baby does get the nutrition from the mother, obviously. Glucose is a big part of that. And part of the hormonal process that occurs naturally in pregnancy is a changing of what insulin works in the body to promote enough glucose or sugar to get into the baby. And there can be some issues that go along with that in gestational diabetes. So that's basically the 3 types and then the 4 subtype prediabetes. Just kind of lay that down as another umbrella type foundation as we whittle away and get a little more specific here in our discussion. So the first one we're going to go over again in order is going to be prediabetes. We're going to talk about this real quick. There's between 90 and 110 million people in the United States that have prediabetes, so it's obviously a big topic. Prediabetes is typically diagnosed using a lab value called A1C. So you'll get some blood drawn. They put it through a machine. They tell you your A1C. A1C is percentages, so it's typically between 5 and 15. And the definition of prediabetes is typically between 5.7 and 6.5. Once your A1C is between 6.5 and 7, that's typically a diagnostic criteria for being diabetic, especially once you get to 7. And then for patients that are diabetic, they're typically going to be between like 7 and 9, hopefully. Once you start going over 9, that's considered uncontrolled diabetes typically. And it can get as high as 11, 12, 13, 14, 15, and so on, just to kind of help us understand that range there and where prediabetes fits into it. Kind of the way I explain this, the analogy I use in terms of prediabetes is imagine you're driving up a hill. It's 100 degrees outside and you have the air conditioner on. And it just puts a lot of workload on the body. So oftentimes for type 2 diabetes, what happens is the body's constantly making insulin, just like that car going up the hill. It never gets a break. And over time, the cells cannot handle what they need, and then their function and their health begins to decline. So that's a big part of prediabetes and what determines if prediabetes transitions into type 2 diabetes. Typically, we're not going to be seeing prediabetics becoming type 1, and we'll explain that when we go over type 1. Typically, prediabetes is always going to go into type 2, just to be clear on that. The second one, in terms of the resistance, because again, it's an issue of production resistance for type 2, in prediabetes, both of those are present, is that imagine you eat ice cream every single day for every single meal. Now, that might sound great for some people out there, but after a day or a couple of weeks of that, I guarantee you're never going to eat ice cream again for the rest of your life or for a very long time. So the analogy I kind of use is like too much of a good thing can become a bad thing. You begin to change your taste, your flavor, your preference, whatever it may be. So that actually can be applied here in prediabetes, is that if those cells are constantly being saturated and bathed in that insulin, and remember we talked about we have an overproduction of insulin, which helps facilitate that. They no longer want to respond to it. They don't want to respond to it, basically. They get bored, and that causes the resistance. So they're resistant to it. Versus the goal is to be sensitive, which is that when you have insulin and it binds, it does its job. So you have insulin sensitivity versus resistance on that level. Some of the things that can also play a role or do play a role in prediabetes, at least for risk factors, are things like weight management, so obesity. Again, diet, like we talked about, eating a lot of carbs, processed carbs, eating carbs or foods that contain carbs that spike really quickly. So there's a concept called glycemic index, and glycemic index is a measurement of how fast the sugar basically gets into the blood. And typically the slower, the better. So if you eat something like a carrot, which is very low in sugar, it takes a long time and the contribution is very little, versus if you drink soda, it's basically sugar and water and absorbs instantly and it spikes the blood sugar, which we don't want. Also, things like exercise can play a role. One reason why that matters is that your muscles are a major site for insulin to bind and a major storage site for glucose to go to. So the muscles absorb the glucose and it lowers the amount in the blood. Turns out when you exercise, especially more than 20 minutes, it makes those muscles more sensitive to insulin. So again, like we said previously, you have sensitivity and resistance. We want to have sensitivity when it comes to insulin. And so anything we can do to increase the sensitivity is going to help us. In the case of exercise, when we stimulate our muscles, it increases the sensitivity, which is good. And it's also just kind of considered a lifestyle disease. So if you're drinking alcohol, smoking tobacco, just generally not really taking care of yourself, those are kind of considered risk factors or hallmarks for prediabetes, and which determines if it progresses into type 2 diabetes. Like we said, again, this affects a lot of people. Roughly 1 out of every 3 adult Americans is pre-diabetic currently, and studies predict that unless something significant happens in 25 years, we can see something like 1 out of every 3 Americans becoming diabetic or being diabetic. And studies have also shown that of the 90 to 110 million Americans that are pre-diabetic, 70% of those potentially will become diabetic type 2 in the coming future as a progression. And I just want to also mention here the concept of CGMs, continuous glucose monitors. Dexcom Stella just came out this week as we're filming this. It's the first non-prescription CGM. And so if you're someone out there who is pre-diabetic or worried about being pre-diabetic, besides getting your A1C measured once or twice a year, I think one of the next best things you can do is wearing a CGM, a continuous glucose monitor, like the one I have right here. Wearing that because it's going to give you a lot of insight into your diet and how your diet affects you and how your exercise affects your blood sugar. And that's really the bulk of what we're talking about today. So I just want to, again, mention that here, that if you're someone who's worried about this, I would go to the website at dexcomstello.com and buy one. It's about $100 a month for 2 sensors. And even if you just do it once, it can be life-changing. I personally recommend to everyone now to do it once or twice a year just to collect that data, because it's one of the best ways to understand what you're doing wrong and what you're doing right. And if you don't have that data, that's really hard to understand. Next one we're going to go into, because we're kind of going in order here, is type 1 diabetes. So some of the main things to learn about this one is that, again, like I said, it's a lack of making insulin. So we're going to get into that. Typically develops at a younger age. Roughly 70% of type 1 diabetics either have onset or diagnosis after age 30. Although we are seeing more and more people who are becoming type 1 diabetic at a later phase of life beyond 30, which wasn't so much the case 20 or 30 years ago, and they weren't really catching as much. Other thing to mention, so again, it mainly affects kids and teenagers. Type 1 diabetes is one of the most common childhood diseases, and currently there's about 300,000 children in the United States under age 20 who are type 1 diabetic. So how it works is that you basically had some type of a viral infection is the current consensus. They're still not 100% certain because it's hard to measure these things. But you had some type of a viral infection, which caused the immune system to kind of do things it wasn't supposed to do. And the immune system attacks the pancreas, which is where insulin's made, the beta cells. This is called autoimmune disease. For people who are familiar with that term, auto is self, immune is the immune system. So basically you get a viral infection, the immune system attacks the beta cells in the pancreas, destroys the ability to make insulin, and basically you no longer make insulin. And this is why patients who are type 1 diabetic are going to be injecting insulin, is they make no insulin. And like we talked about in the introduction, you need insulin to get the sugar or the glucose into the cells. And so that's why they have to inject it. That's why they rely on injections. So again, the big takeaway from type 1 diabetes is you don't make insulin, which is why you have to inject it. And like we've already said before, insulin is necessary for life, which is why it causes a disease. It also can be very difficult to match your blood sugar with the amount of insulin you inject. So that's going to be one of the main challenges. Your ability to inject insulin is much more difficult to be accurate than when your body does it by itself. So just knowing I ate XYZ and I need W amount of units of insulin is not that easy. At the same time, when you have stress, adrenaline, all those things can affect your blood sugar. So there's other things you have to count when you're figuring out how much insulin to use. And the liver also makes a lot of glucose itself. And so you also have to be able to match your insulin injection usage with the amount of glucose the liver itself is also making, just to kind of give some background into that. Like I said, in terms of the diagnosis, it does typically occur when you're younger, under 10, under 20 primarily. We're going to talk about quickly what that might look like. So there's a term called diabetic ketoacidosis, DKA. This is what happens when you don't have enough insulin. Your blood sugar gets really high. The reason why it gets so high is that the muscles and the cells can't absorb it. And when the muscles and the cells can't absorb glucose, which is a form of energy, they have to make energy a different way. In this case, because they can't use glucose, they use fat. And the result of using fat for energy for a prolonged period of time is you make a byproduct called a ketone. And those ketones, when they build up, they're not good for the body. They change the acidity, they change the metabolism, they cause issues. It can actually become life-threatening. And that's what diabetic ketoacidosis is. This is a term that a lot of diabetics even aren't familiar with, and I'm always educating patients who are diabetic what it means and what to look for and what it does. This is typically how a lot of children especially are diagnosed with being type 1. They're not really aware of the symptoms, and so they basically become DKA. They have the health issues and the symptoms, which will go over to the next slide. But typically it's nausea, vomiting, and GI issues. That causes them to go to the hospital, and then a part of the workup, they basically become diagnosed. When most patients who are type 1 are effectively or eventually diagnosed, typically 80 and 90% of all the beta cells have already been destroyed. So again, the beta cells or the insulin's produced. So I just want to quantify with the number here that typically, again, like we said, when you are diagnosed with type 1, you've basically lost virtually all the ability to make insulin. And the A1C can also be a factor of that. Oftentimes, the A1C is going to be elevated. Some of the other things I might look for when the diagnosis is just the history of the patient and the child. So their weight. They can also check for antibodies in labs. They look for something like C-peptide, which is associated with insulin production. So there's some other labs that they can also use besides the autoimmune component to it. And that ultimately between 85 and 90% of the individuals who do have type 1 have these antibodies circulating that can be measured. So again, they're going to do a blood test. They're going to look for things in your immune system that are hallmarks of your body's response. In terms of the issues or potential side effects of being type 1, The biggest ones, especially for the children who are yet diagnosed, is going to be going to the bathroom a lot at night. Nocturia is what it's called. The reason why this happens is that when you're not absorbing the sugar, you're going to urinate it out. The urine itself has a much higher concentration of sugar or glucose than normal, which makes a lot of water go into it because wherever you have sugar, water follows, increases the volume of urine, and that's why you're constantly going to the bathroom. And oftentimes when you're sleeping, this can also lead to incontinence issues because, again, always having to go to the bathroom, especially when you're sleeping. And most patients, when they effectively do become diagnosed, they have a several-week history of polyuria, polydipsia, which is a fancy word for always going to the bathroom or always thirsty. Because if you're always going to the bathroom, you're going to have to drink fluids to get that. You also will see things like weight loss because, like I said, you can't use the glucose for energy. So the body effectively becomes starved, has to start using fat instead. And so you will see a lot of weight loss in type 1 diabetics prior to being diagnosed, especially when it's not being treated, because the lack of insulin allows them to utilize a normal form of energy. And then, again, the idea is that we're having to use a secondary source when we're going DKA, which requires the ketone production, which is why that's typically a symptom or a complication. In terms of some risk factors of type 1, I just want to include these just for completeness. Generally speaking, when they look at the data, most people who are type 1 don't have a relative. There is some potential risk that can be passed on. So if you do have a parent that is a diabetic or type 1 diabetic in this case, it can increase the risk from 1 in 50 to 1 in 20. So there is some correlation, but I believe it's something like only 40% of type 1 diabetics have a relative or a parent who was type 1 diabetic. So it's not 100% genetic. It is, again, like environmental when you have this exposure to the viral infection, like we mentioned, which again basically is, the immune system attacking the beta cells in the pancreas, causing those problems. So again, we already went over ketones. Just to touch on that, we're going to go to the symptoms because everyone needs to know what diabetic ketoacidosis looks like. Again, this results in using fat for energy instead of glucose, which produces the ketones as the byproduct. This can be a life-threatening emergency when it happens. It typically occurs when the blood sugar or blood glucose goes above 400 for more than a couple hours, a couple days. And the symptoms are going to be really thirsty, going to the bathroom a lot, which I already mentioned. You're always hungry, but you're tired at the same time. You could have a lot of weight loss. Blurry vision is more of an acute symptom. Again, fruity smelling breath is one of the hallmarks of it. So you have ketone breath. For people out there who fast a lot, like myself, I definitely will get ketone breath. That's, again, because I'm fasting. My body is using fat for energy. It's very fruity smelling, almost like an alcohol smell. And you can also get a lot of stomach pain when you have acute DKA going on. So typically I educate patients, fruity smelling breath, blurred vision, really weird stomach pain, upset stomach, you just don't feel well, very low energy. That can be a great time to use a ketone urine test stick if you already have those at home. So you can basically urinate in a cup and put the test stick in there and it tells you if there's ketones in it, or you may have to go to the doctor and have them do the lab. So again, if you're a type 1 diabetic out there and you're watching this, definitely make sure you have the ketone test strips at home because that's important to look for. And then just to wrap that up, I just want to kind of touch on real quick the different treatment options for type 1 diabetes. Typically always using insulin. Because like I said, you're not making insulin. So ideally you're using rapid and long acting because using those both together makes it easier to match what your body needs. Typically use rapid acting injections to cover meals and then use a long acting one to cover the liver's constant production and to keep the levels where you want them to be for a prolonged period of time. Some quick points to mention there is you generally want to avoid premix insulins. So premix is when the rapid and the long acting are in the same one. They don't work as well because you can't tailor the dose. It's a fixed ratio. And if you want more rapid and less long or vice versa, you don't have that ability. I also want to mention I'm a big proponent of insulin pumps for type 1 diabetics, especially the Omnipod. That is my preference for these people who are eligible for it. You basically use your CGM to measure the blood sugar. You wear a little pod, typically down here, which has 1 or 2 milliliters of insulin in it, and the two systems connect, and the pod gives you the injections, which is really great because you no longer have to give yourself the injections, and at the same time, the computer will actually help gauge how much insulin you need, and the computer actually does the dosing, which is really cool because in this case, when the CGM provides the data and the computer reviews the data, it makes a better decision than you do. It looks at all the trends and the prior responses to basically further enhance its ability to make the best decision possible. So again, Omnipod's really cool. If you're type 1 diabetic, you're not familiar with it, definitely check it out. Talk to your doctor about it. I think it's the future. It's one of my favorite treatment options for these patients. Again, same thing with the CGMs. That's a continuous glucose meter, whether it's a Dexcom or a Freestyle Libre. You need to know what your blood sugar is to be effective and safe. especially when you're using insulin. And when you're pricking your finger, you're not really collecting all that data. At the same time, the CGM can do alerts. So you can say when it goes above, 200, 250, 300, whatever it is, let me know. Same thing when it gets too low. If it goes below 100, below 70, below 50, let me know. And that really enhances the safety of insulin, because insulin can be dangerous when used improperly. And diabetes in itself can become dangerous when not treated properly. So the CGM is super, super powerful for empowering those patients to know what's going on, whether it's how their diet affects their blood sugar, how to properly dose their insulin, and when they don't properly dose it, if they're using too much or not enough. And with, again, those alerts allowing them to react proactively in treating highs and lows before it becomes a real problem. It's a complete game changer. If you're a type 1 diabetic out there and you don't wear a CGM, you need to talk to your doctor today, get that taken care of. Hypoglycemia is a serious condition. It's potentially life-threatening. You can go into a diabetic coma. And this typically occurs when the blood sugar goes below 70. And when it goes below 50 or 55, it's a real concern. And in terms of treatment for type 1, just to wrap that up, typically those patients are going to see their doctor every 90 days. It could be more than 90 days if they're really well controlled, but definitely important to always get checked in and get a checkup. So that's type 1 diabetes. And basically, again, like I said, it's where you don't make insulin. Next up is going to be type 2. The hallmarks here is you can produce some insulin, but not enough. And that in part is because you were making too much for too long, and the cells kind of basically gave up and lost the ability to do their job. The analogy I would use here is like, imagine leaving your car on for too long, or revving your engine up for too long, the engine overheats, which is why I use the analogy of driving up the hill. So basically you ask your body to do something it couldn't do for too long, and the result is to basically blow out those components of your engine, or your body in this case. The second component of type 2, again, like I said, is the resistance. I use that analogy of eating ice cream for every meal. Eventually you're gonna be like, please, please, please get that insulin away from, or that ice cream away from me. I can't handle it. I have no interest in it. Same thing with your body. The cells and the receptors are so bathed in insulin that they just don't want to use it anymore. They deregulate, downregulate, and just don't want to interact with it anymore. And so that's what causes type 2, is that you can't make enough because you basically lost the ability to make ideal amounts. And at the same time, also that increased level of insulin causes that resistance, and then now it doesn't function. So that's basically what type 2 is. The other thing to be mindful of here is there is also a component with the liver. So the liver does typically make sugar, excuse me. And when you have that overproduction of insulin, it changes the way the liver works. And it can actually cause it to make its own fatty acids as a secondary fuel source. And that changes the distribution of fats in the body. And just to kind of go as a quick aside, that's why type 2 diabetics and diabetics in general have to be careful with fats in their diet, because their liver is doing weird things, and they typically have increased risk for atherosclerosis, which is a fancy word for fat deposits in your blood vessels. The insulin resistance can also result in a reduction of the sugar uptake or the glucose uptake in your muscles by 50%, which results in that elevated sugars for a prolonged period of time. The technical term is postprandial hypoglycemia. So let's kind of include that, and to be complete is you do have the insulin production, the receptors, but you also have the liver playing a role and the muscles playing a role to kind of give you a further picture of what's really going on there. In terms of the risk factors, just want to include those real quick because a lot of people might be concerned or want to know what those are. There is some family history, again, for type 2. It's about a 30 to 40% increased risk if your family member is diabetic. Obesity can play a big one. So again, BMIs over 30 is really to get concerned. If you have had a history of gestational diabetes, that is a risk factor. What I would describe is just overall inactive behavior. So people who don't exercise a lot, that can play a role. Like we said, the muscles are a major site of sugar or glucose uptake, and they become more sensitive to insulin when we exercise. So if people are not active, that basically is going to promote insulin resistance, which again, we now understand is a major cause of type 2 diabetes. There is also some ethnicity component to here. So certain ethnic groups do play a role with having a higher risk factor. In terms of the symptoms of type 2, the ones that you may typically notice are going to be fatigue, and always thirsty, and always hungry. So as we call it the 3 Ps. Also things like blurred vision. We described weight loss because you can't absorb the glucose into the cells, so they use fat instead. You can also see things like slow wound healing. This is typically a little bit further on. Cuts, scrapes, and blisters, they don't respond properly, which is why diabetic ulcers happen, especially foot ulcers. And then long-term, some of the other issues can be things like numbness and tingling in the feet, just to kind of give some examples there. I do also want to talk about the treatment real quick, just to kind of provide some information. It's complete here. The first one's obviously lifestyle. So like we said, weight management, getting your BMI under 30, getting your diet properly done, which is very simply put, lower carbs, lack of processed foods, more vegetables, potentially smaller meals, things like that. Exercise is really important because one, it does make the muscles more sensitive to insulin, which again, like I said, can reduce the effect of the resistance of the insulin, which is a hallmark here. And also things like screenings. So if it is progressing in the wrong direction, we can be mindful of that. And the examples for that would either be getting your A1C done once or twice a year, or also wearing a CGM to have a better idea of how your blood sugar is responding to the treatment and your lifestyle modifications. Really quickly, I just do want to kind of mention the medications we most commonly see here for type 2, just to kind of people an idea. These are not all the medications, but these are the ones that the guidelines recommend. This is more so what the cutting edge is, which is why I want to mention it here. If this is not what your protocol looks like, you may want to talk to your doctor about why it's not. Again, this is very general information. It may not fit for everyone, but this is just for educational purposes. So for type 2, typically metformin is described as first on, last off. That's the first medication you're going to be taking that's oral. The next one is going to be an SGLT2, which is something like Jardiance or Farxiga and Vilcana. These medications are really cool because they help with the kidney and they help with the heart. So what's really cool with SGLT2s is they target multiple issues in a way that's never existed before, and that's why they work so well. They can also be very effective for lowering your blood sugar, so that's a really cool drug, and that's what I recommend all patients in the situation to be on. You also have the new GLP-1s, which are really popular, something like Ozempic and Trulicity, and Mounjaro, which is a slightly different drug class. Those can basically help with your blood sugar, mainly through diet, but also through ways that the hormones work in the body as well, so we know about those. The next class is going to be something like Januvia or Tradjenta, which is the DPP class. This changes the way some of the hormones in your intestines work, somewhat similar to Ozempic. It basically tells the brain you're full or to digest things differently, and it helps lower the blood sugar. I also want to mention for things that are not diabetic, but diabetic related that are important for treatment, which is blood pressure. Most diabetic patients will have blood pressure issues or cardiovascular disease issues. It's really important to be on an ACE inhibitor for blood pressure medication, so something like lisinopril. The reason why I'm saying this is not all diabetics are on ACE inhibitors, and studies have shown that ACE inhibitors protect the kidney. And so again, when you're diabetic, we're worried about kidney disease. Like we mentioned with SGLT2s, ACE inhibitors are the same thing. They confer a renal or kidney protective benefit, which is really important for maintaining long-term health for diabetics. Also, another one that is related is treating cholesterol, or LDL specifically. So making sure you're on a statin. These are things like atorvastatin, simvastatin. Those are the most common ones. Rosuvastatin. That's really important because, like we said earlier, when you have insulin issues, the liver does weird things. It can be increase in the fatty acid production. And in general, diabetics have increased risk for atherosclerosis, which is one of the number one causes of heart disease, which is basically fatty buildup or plaques in the arteries. So it's really important to take a cholesterol medication, or a statin, to help treat or minimize that. And again, also emphasizing the role that continuous glucose monitors can play, collecting that data. The last one to go over here is gestational. Like we said in the introduction, this is typically related to pregnant women. It typically occurs between 2 to 10% of pregnant women, and it's basically due to needing to get enough nutrition in the baby. The mother, in this case, responds to those changes a little bit more than normal, which results in even more insulin resistance and results in basically concern for diabetes. We are worried about it affecting the baby. So it can affect the baby's birth weight. It can affect basically babies being born preterm. There's a lot of health issues that can go along with there. And then also for the mother, it's one of the leading risk factors for preeclampsia. Preeclampsia is when you have a fluid imbalance or a high blood pressure issue going into delivery. It can become life-threatening, and gestational diabetes is a leading risk factor for that. It also becomes a risk factor for the mother later in life becoming diabetic. So gestational diabetes can definitely affect the baby and the mother, and it basically becomes a risk factor for the mother later in life as well as the baby, because if you were born gestational diabetic baby, then you have increased risk yourself. And again, it results from the body trying to make sure the baby gets enough sugar or glucose, but going a little bit too far and basically causing too much insulin resistance. Hopefully it goes back to normal after the baby is born for the mother, but generally speaking, about half of women with gestational diabetes will have a real increased risk or future risk for becoming diabetic themselves. And then a really common question we get is, how is this diagnosed? So if you're pregnant and you're worried about this, it's a really simple test. At around 24 weeks, you go to your doctor and you get what's called the oral glucose tolerance test, OGTT. It's basically a fancy word for you drink some sugar water. So it's got 75 grams of sugar in it, and they measure your blood sugar in at least 2 hours, typically before and after. And basically, if your blood sugar is over a valued amount at 2 hours, they can use that to help diagnose and understand that. If after 2 hours, your blood sugar is below the goal, which is typically 180, that implies you don't really have a lot of insulin resistance, and that's the hallmark that they use to test for that. So again, the goal for today is just to kind of give you some really simple, really easy background information. Prediabetes versus type 1 diabetes versus type 2 diabetes versus gestational diabetes. Focusing on the terminology, the basics about each one, what makes them different, what's similar, so you can have more of an understanding, and when these conversations happen, you can feel comfortable talking about them. We've all been there when people use words we don't understand. We can't follow along, and diabetes is a major topic right now, so we want to help empower people to understand that. I just want to close here with, again, how are these things tested for? So especially for type 2, that's where it primarily comes into. We're going to be doing things like fasting blood sugar or hemoglobin A1C. Those are both simple labs we can do. And for a gestational or pregnant woman, it's typically the oral glucose tolerance test. And for type 1 diabetics, typically we're going to be looking at antibodies in the immune system, as well as C-peptide, which is a byproduct of insulin. So we know if we find those or don't find those, we have a good idea of type 1, as well as, like I said, type 1 diabetics typically present with symptoms. Typically DKA is the most common one, which is a sign of elevated blood sugar. If you have any other questions or concerns, please feel free to send us a message. We take comments on the YouTube channel here, as well as emails. So you can email me at welcome@yourpersonalpharmacy.net. If you like this information, please subscribe and follow the channel. Again, we're continuing our diabetes education series here. We have a few videos already, so if you haven't seen those, check that out. And there's going to be more to come, like I said. If you also want to learn more about our pharmacy or any other health information, you can find us at yourpersonalpharmacy.net. We also have our online supplement store there, so if you're looking for supplements and you find that overwhelming, which most people do, we can help you out with that. And also in the future, again, like I said, check out the future videos, because what we're going to be doing is taking the online diabetes self-management education curriculum, which is really great, and we're going to be digitizing that and putting the videos to make it more available to the people. So again, my name is Kris. I'm the Helpful Pharmacist. I'm a pharmacist and a biochemist, and hopefully today you learned something about the difference between diabetes. Thank you.